Eid Mubarak. I welcome the participants to the AU Alliance webinar, Fracture-Related Infections in Low-Income Countries, its Prevention and Management. I am Dr. OFG Kibriya, consultant orthopedics from Dhaka, Bangladesh. I work in two hospitals, Apollo Hospital, Dhaka, which is a multidisciplinary 450-bed hospital. It's a tertiary care hospital, and at the same time, is the only Joint Commission accredited hospital in the country. I work in another hospital, Japan Bangladesh Friendship Hospital, which is a 100-bed hospital for the low-income people. Today I have with me Dr. Leonard Banza from Malawi. As a moderator, I'd request Dr. Banza to introduce himself.
Thank you, Dr. Kibriya. My name is Banza. I work in Lilongwe. It's the capital city of Malawi at Kamuzu Central Hospital. My role this afternoon will be the chat moderator. I will be receiving your questions. I will be answering to some of your questions, and some of your questions will be kept for the period of questions and answer. Thank you so much, Dr. Kibriya.
So, our agenda for the next 45 minutes will be the webinar, Fracture-Related Infections in Low-Income Countries, Prevention and Management. We'll have live question and answer period, and at the end we'll have offline chat answering of the additional questions. After this webinar, the learning outcomes for the participants will be, they will be able to apply a structured approach to making the diagnosis of an infection related to a fracture. They will be able to describe the treatment protocols that are useful to treat infections following fractures in resource-poor settings. Recognize their value for improving patient outcome. Implement the correct treatment. I repeat, the correct treatment for the specific infection. That means, as a surgeon, we have to do surgery, we have to choose implants, and we have to do the correct surgery like debridement and choose the proper implant to keep the implant in a situation of infection or not to keep it. So this is one learning point we'll have today. And at the same time, we'll learn some behavioral changes to promote infection prevention. You understand that this is a huge topic. It's beyond the capability of today's talk in 45 minutes. But we are going to structure or outline the whole talk into subtopics, subtitles like introduction, pathogenesis, the classifications, the diagnosis, the treatment options. We will have some clinical case discussion as well. And at the end, we'll talk about the summary and the take-home message. Our reality in the low-income countries. You know, in the low-income countries, the situation totally differs with the other developed countries. Like, we don't have a setup which is safe. Sometimes we don't have enough manpower. The OT theater, operation room theater, sometimes are different with respect to the developing countries. The patients also, they are sometimes feared of the surgeries. They do not come to the proper place for the communication problems as well. Can you see this picture? This is one case that presented to us in our locality Dhaka, that they are going for traditional treatment. So sometimes this is also used to transfer the patient from one place to another, but below this, some bone setters, they use some medicine to treat the patients. So all these causes some delayed presentation to a higher center, which leads to a complicated surgery, longer time. So the patients also do not come often to the follow-up. So we call it a poor follow-up because for their needs, for other reasons, they cannot come or they are fear not to come to this place in the hospitals. So the poor follow-up altogether in the reality is that a large proportion of individuals with the surgical infections are left with disability or sometimes death may occur. The fracture management goal, while treating a case of fracture, a surgeon has a target. Our aims are to have bony union with fewer complications, restore the limb function, avoid complications such as of soft tissues or bony like osteomyelitis, because these infections or complications lowers the limb function. Patients may have psychological and social dysfunction. The costs are also increased, sometimes may lead to amputation. This gentleman, Martin Algoer, who is one of the founder members of AO Foundation as well, he has written many books on basic principles of management of orthopedic surgery. In 1975, he made a statement. The risk of infection remains the crucial issue of internal fixation. I think we all agree today, 40 years later, this statement is still valid. This is the classification, I think you all know, the Castillo-Anderson's classification of open fractures. This is classified from 1 to 3 depending on the severity. And the soft tissue injury, ABC, 3 is subdivided into ABC based on the soft tissue injury, which may need to soft tissue coverage. And 3C is the severe of all with a vascular injury. So you can see the rate of infection going up from 1 to 3. From 1 to 3C, it is going up. But at 3C, it is 8%, while in 3B, it is 20%, because the severity of the injury, 25% of the patients get amputated. So in an open fracture, with the severity of the injury, there is a chance of increasing of infection. So you need to take care of open fracture cases very well. There is another study by Oschner, PE, from German article. The incidence of infection after surgery is about less than 1% for closed fractures and over 6 to 7% for open fractures. This is for a developed country, except Gastello type 3B and 3C, because from the type 1 to 3A, these are all soft tissue coverage possible. So in a study of soft tissue coverage where possible, even then the open fractures has got more chance of infection rate. So another important part from the message is that you need to take care of the open fractures as well while treating the closed fractures at the same time, that these open fracture cases has got more chance of getting infected. Now the pathology of infection. How does the infection happens? First of all, bacteria needs access to the host. There should be skin break, either by the trauma itself or by the surgery. The bacteria need an environment to flourish that offers by nutrients. The local trauma, seroma and blood gives rise to nutrients to that bacteria and allows it to grow, and relatively safety from the host defense, so that the defense doesn't kill them. Either they support a biofilm, which is a protein coverage on the implant, or the dead tissues, avascular tissues, gives enough food for the bacteria to flourish and increase their in numbers. So these are the pathology of the infections. Why do fractures get infected? The causes we have been grouped into 4 categories, like the patient's factors, the surgeon's factors, the bacteria factors, and the implant factors. We'll go one by one. The patient's factors, mostly that personality of the injury is important, which includes the fracture pattern, soft tissue injury, and the patient's age, the comorbidities like diabetes and hypertension. Certain patients, they use certain drugs which compromises the immunity of the patients. Sometimes the patients might have a dental infection. So all these factors comes to promote infection in a patient. The surgeon factor, rather a surgeon's team factor, because it is related to the procedure related. In an emergency surgery, you might skip some of the basic principles. In cases where you prolong the surgery, the duration is increased, so the wound remains open, there is chance of more infection. The surgical technique, that implies to the surgical team mostly, because if the surgery is meticulous and soft, handling of soft tissues is very careful, there is not much tissue necrosis, so the chance of infection will be less. And the timing of surgery. That means in cases of an open fracture, if you're doing the surgery early or late, that might be a reason to cause infection of that specific patient. The most important of all is the operating room environment in LICs. You understand, in the low income countries, there is insufficient staff, not enough money, not enough medicine sometimes. So altogether, and there's not enough safe staff to have a safe surgery or trained staff. So altogether, the operating room environment differs. But in spite of all that, if we can go through a systemic approach, we may have low an amount of infections in that places. One of the important part is bacterial factors, the biofilm formation. The biofilm word, you understand, there is a protein coverage on the implant which colonizes the bacteria and prevents body defense mechanism to kill the bacteria. So biofilm formation along with the implant is an important point to get an infection. But we need to understand the principle so that we can heal the fracture and do not get infection. Another important point is virulence of the organism. There are certain organisms which are very virulent, like staph. They are not killed by ordinary normal antibiotics. So you need a special like flucloxacillin or linezolid, whatever it is. So virulence is an important part. And at the same time, the medium to grow around the implant, hematoma, seroma, or fluid collection should be avoided so that there is not much enough food for the bacteria to grow. The implant surface is sometimes critical. If there is a rough surface, there is more adhesion of the protein, thicker the biofilm, more colonized bacteria. An open fracture offers an easy entry to fracture site. So in an open fracture case, you need to take care properly so that the patient doesn't have an infection. The implant itself, the metal surface get rapidly covered with the proteins as we have told in the bacterial part. Bacteria adheres to the surface and stimulated by adhesion to proliferation. That means while we choose the implants, if possible, we can have a smoother surface implant. It's better. But I don't think in low-income countries we have much choices. The common organisms that we find in Staphylococcus aureus, group A Streptococcus enterobacteria. There has been recent rise in Staphylococcus epidermidis, the methicillin-resistant Staph aureus. And there is a scope of nosocomial infection in an area where multi-drug resistant organisms are also available. So you need to have a culture and decide which organism is responsible for the infection. The pathogenesis, that means the spread of the bacteria may be hematogenous, especially in children, or the contiguous focus of infection if within the area of the injury or the surgery there is a focus of infection which may spread from that area to that surgical site. Direct contamination may be due to open fractures commonly or some of the surgeon's team contact, it may be operative methods, maybe direct plantation of the bacteria into the surgical site. The infections may be superficial, involving the soft tissues only. The moderate, it may involve the bone as well, sometimes very severe. There may be chances of gas gangrene or tetanus, which might endanger the life of a patient. There are many ways of classifying the osteomyelitis. One is based on duration, we call it acute. When we get the patient of 10 to 14 days of surgery or open fracture, or we call it subacute, when we get them after 14 days. In the X-ray, we can see some osteoporosis around the screw or plate or the implant. Patient may have associated pain. We also call it chronic when we get them after 10 weeks. Usually it is sequelae to acute. But this classification doesn't indicate the anatomical location of the infection or how it has happened. Neither it helps us to plan surgery. We have another classification, Sandy Mader, described in 1985. He has stepped 4 types. medullary, superficial, localized, and diffuse. These are bone and bone marrow infections, direct inoculation by trauma or surgery or blood-borne organisms. It helps in planning the treatment. The medullary meaning usually it is by hematogen spread or you can have through intermedullary nailing. So if you know how it has happened, you can plan the next treatment. The superficial involves the cortex and the superficial tissue. So you can plan the debridement on the one cortex and soft tissue at the same time. The third type is a localized one, which involves the cortex and the medulla, but the bone is stable. So you know the bones is stable, so debridement may be enough. And the diffuse one, which involves both the cortexes and the medulla at the same time and makes the bone unstable. So you know you need to do something to attain stability. The influences on infection, the dead soft tissues. Dead soft tissues allows more food to the bacteria so that they can proliferate in number and get an infection. To avoid this, you can avoid closing wounds under tension, prevent damage to muscle and tendons. That means meticulous surgical technique is a guide and gentleness in the guide to avoid infection in any surgeries. The influences on infection on dead heart tissues. Dead heart tissues are at the same time allows to colonize bacteria and prevents the body defense mechanism to reach or kill that bacteria. So while treating an infection, if there is a dead heart tissue, you need to remove or excise all of them and excise all the foreign bodies at the same time. So in a case of adequate debridement, if especially in open fracture, is an important surgical strategy not to have an infection in such a case. That means when you are treating a infected case or osteomyelitis case, good debridement prevents and treats at the same time. And you must know the dead heart tissue, how to identify and remove them from that place. Once you suspect a case with infection or osteomyelitis after surgery or after trauma, you must take a good history, which may give rise to an idea that whether there is pain, fever, headache, nausea, vomiting. And you must go through the objective clinical examination. There may be erythema, local swelling, tenderness, there may be presence of sinus tract, there may be drainage of material, patients might have limp, you might get a fluctuation test positive. You must see some of the laboratory tests available like C-reactive protein, leukocytes, lymphocyte emission rate. If possible, take a gram stain to see the bacteria. And of course, in the X-rays, you might find the implant loosening, which can give you a diagnosis whether the patient has got a infection or not. The X-rays are also a good guide. In the X-rays, if you look into the soft tissue linings, there may be swelling, obscured soft tissue planes, there may be haziness. In the bones, there may be seen hyperemia, so leading to osteoporotic changes or blackening of the areas. If there is lysis, you understand more than 40% bone has been resolved. The lacking of periosteal reaction and sclerosis of the margin. So these are the few guidelines that can give you an idea through radiologically to diagnose a case of infection. After you have diagnosed the infection, there may be 4 clinical scenarios. The infection before fracture union, infection with healed fracture, infected non-union with stable hardware, infected non-union with loose hardware. So this is a situation where you understand that the confusion comes to keep the stable hardware, not to keep. So those who are participants or listening to us, if you have any questions, we can put through our chat line. So Dr. Banza can answer some of your questions. Now, I have a question for you. So, which one of the following operated patients has an infection? Patient A only, B only, neither of the patients, both the patients, or you cannot decide. Kindly click your answers and we can see. So we can see the scoreboard that there has been patient A only in 27%. Both the patients have D has 52% and cannot decide have 8%. I think the correct answer is both patients, both of them are infected. So now we come, after we have diagnosed, now we come to the treatment principles. We need to choose antibiotics culture directed and clinically driven duration. That means this is a place you need to choose an antibiotic, preferably on the culture sensitivity. And while you are doing debridement, you should send it for histopathology, which might guide you something. Clinically driven duration means clinically you judge how long you need to continue the antibiotic. In some cases, the advocacy has been you can use the specific antibiotic for 2 weeks intravenous, followed by 3 months if there is an implant, and if there is no implant, 6 weeks without implants, and for oral by oral medication. So these are guidelines. You have to, based on your local culture, you have to choose the antibiotic and the duration as well. The debridement, this is the most important part. Surgical infection, the treatment is surgery. That means debridement is the most important part and antibiotics is secondary. By debridement, you do remove all the dead tissues and necrotic tissues so that the viable tissue is obtained, and you continue the antibiotic so that it prevents local bacteria to grow up till the healthy tissue covers the dead space. You may need some irrigation. You may need to clear up the wound. Sometimes you might have to cover the wound with soft tissue. So wound care for dressing changes, you have to do it a sterile way. At the last, and one of the most important is the osseous and soft tissue stability. The fracture stability is important to heal an infection. After you have got attained stability, you need to go for dead space management. The dead space management, to heal the bone, you might have to use bone graft, bead pouches, that means bone cement mixed with antibiotic. You might have to go for a bone transport through Elizarov, or you might have to use a vascularized graft. So once you look into all these issues, the controlling of infection is really difficult and complex. So prevention is a lot easier. If you can prevent them, that is a better option for all. Role of antibiotics in fracture surgery. The antibiotic is complementary to surgery. So you can use in a routine surgery prophylactic antibiotics reduces the risk of infection. So before putting the tourniquet, you can use a single dose or maximum second one after 24 hours depending on your local scenario. Prophylactic antibiotics are not a substitute for careful surgical technique. This is the most important part. That means surgical technique is not a replacement. Surgical technique cannot be replaced by antibiotics. So now you come for the treatment of superficial infections. First of all, you have to drain that abscess. That means drain, remove all dead tissues, membranes, anything is dead, you have to remove that. You have to clear it so that the number of bacteria is reduced, wound lavage we call it. If it is possible, identify the organism and treat accordingly, or empirically, you have to use a broad spectrum antibiotic. And depending on the culture, you can choose your own antibiotic later on. But while treating a superficial infection, do not neglect the possibility of a deep infection. So just remember, something which is looking at superficial infection, it might have a deep infection as well. So treatment of deep infection is very important because it involves the bone, cortex and medulla, which is not always easy. You have to suppress the infection until the bone heals. Sometimes you might have to remove the hardware and debride the bone. Sometimes you need to cover the soft tissue by muscle flap or soft tissue coverage, soft tissue flap. But stability you need most important to allow fracture healing, which you can achieve through either the original implants. If you have removed the implants, you can put X-fix. Sometimes a ring fixator can do the both at the same time. This is a scenario. Can you see? This treatment depends on maintaining stability. How is that? This particular patient had infection. If you see this, if you look at this place, the bony gap is there. There is one screw. There were two screws. One screw was removed during debridement. It has not united at the same time, and there is some gap, but there is some bony projection available at the same time. So in one case, the rational has been used, and there is a LCP has been used. So after debridement antibiotic, you can see it has healed. So this is a case from Mozambique patient, HIV positive, had open fracture of the tibia, and the pain was there and not united. So this can be treated in a way like you can remove the implant, put an X-fix, debride, put bone graft. So there are some times if you put the bone graft, it might get absorbed. So in a situation like that, we call it a membrane-induced technique. Can help you. This is a membrane-induced technique of muscovalate is a process where you have to debride at the site of the infection and stabilize that. So you can put a cement spacer in place and if necessary, put a flap cover. This cement spacer is placed there for 4 to 6 weeks, which gives rise to a pseudomembrane. And if you put graft into that membrane after 5 to 6 weeks time, there is less chance that this bone graft might get absorbed. So in the stage 2, you remove the spacer, fill with morcellized bone graft. So this is a muscular technique we call it. You can also do it in need if you want to. So the implant paradox is that implant in one reservoir of bacteria and biofilm avoids the local immune response, but at the other side it gives stability. So you have to judge on your clinical basis whether to go with the implant or to remove it. We'll give you some guidelines. So acute infection following ORIF is the removal implant mandatory. What are your goals? Your goals is first eradication of the infection and maintain an internal fixation if possible. How do you do that? So you can go for a repeated debridement every 48 hours with local and systemic antibiotic therapy. The wound must be bacteriologically clean after 4 surgeries. If not, then you can remove the implant. Any implant or device providing mechanical stability should stay in place in acute setting. And loose implants should be removed and replaced to optimize the fixation. You must remember a rigidly fixed fracture can unite in spite of infection. Internal fixation of open fractures reduces the infection rate. So everything stable fixation and implant are in favor of controlling infection. So you must judge and understand in your situation whether to remove or keep the implant what you are fixed for. So now I have another question for you, question number 2. Should the implant be removed when debridement is done? Put your vote on the question answers A, B, C, D and choose your answer. So there has been 13% answers they want to remove the implant. There is 40% they don't, no matter, they want to maintain the implant. And there is remove and apply X fix, there are 43%. So my question is, looking at this picture only, can you really decide to remove or keep it? You must debride, clinically judge on the table whether the implant is really loose or not. So the right answer should have been, you can't decide seeing only this picture. So the picture is not a guideline. The guideline is you must go and examine properly and judge on the table depending on the debridement and whether the implant is loose or not. So there is only one thing worse than a stable infected fracture, and that is an unstable infected fracture. So if you remember this conclusion, you must treat the infection and while maintaining the stability. Either remove the implant concerned, put something else, or go with the implant. But the stability, no compromise. Now we have some clinical case discussions just to share our knowledge with you in a scenarios in low income countries. This is a 45-year-old woman fell from rickshaw. I think many of you are not concerned with the rickshaw. Have you seen? This is a rickshaw in Dhaka. Traveling through that, lot of people, low income people travels through these. Those who do not use government transport or personal transport they have, you can see it's very risky. If there is a break, suddenly the patient might fly off the transport, so get a fracture or like this. He was treated in a local hospital with tension band wiring and screws, but ended up with infection. So in the same hospital, the implants were removed, but there was discharge coming from the skin. So she went to some other higher centers where they put the bone cement. Possibly they tried to do a Muscular technique, but patient did not report to the same hospital after 6 weeks. So he came to us after 3 months when it was inadequate to remove the implant and put some bone graft. At the same time, she was having movement at the fracture's non-union side, not at the joint. She was reluctant to undergo any other surgeries. So now she is living with a permanent disability like this. So if we could prevent her getting infected, she might have got a good life. This is a 25-year-old man, closed fracture right patella. Tension band wiring was done in a peripheral center. He presented to us with a skin loss and exposed implant after 2 weeks of surgery. So you can see after 2 weeks of surgery, this is between and after the just acute stage has subsided, chronic has started like that. So this is a scenario where we had to do an adequate debridement and removal of implant to debridement, and after that the wound looks healthy and the flap cover was given for the medial thigh flap. In some situations, the plastic surgeons, if not available, the surgeons himself had to do that. So after the flap cover, you can see the flap cover is alive, and at the end of 1 month he looks like this. But after that, once he left, he did not turn up. So the poor follow-up is there, but we have controlled the infection, that's true. But function, how much he has achieved, we do not know. This is another case, 33-year-old man, road traffic accident, sustained fracture, both tibias. Both were treated with IM nail. The right leg, he had a Symes amputation with chronic draining sinuses, and the left leg had a superficial infection. The left side nail was removed at 4 months, superficial debridement done, and patellar tendon bearing cast was given. So it got united. On the right side, the ring fixator was used, removing the nail. Compression was given at the fracture site. Ring fixator was removed at 8 months. So you can see this is united on the right side, with a Symes amputation, the X-fix and a PTB plaster given to him. So the three cases we have discussed means it was better if the fracture did not get infected, because treating the infection is more complicated and difficult, costly as well. Sometimes patients do not come for follow-up as well. So it is always better to have prevention. So to prevent fractures or surgeries get infected, do not forget good clinical practice. That means change of culture. If you practice something good in the hospital while seeing and examining patients, this good practice may be a good way of preventing fractures getting infected. Good practice in the clinic and the ward. What is that? No surgeon wants his complication to face his own complications, but do not ignore the signs of infection at the first time. If the patient is complaining of pain, there is delay in wound healing, there are signs of inflammation or increased drainage, clinically judge that and go for the surgery if needed. If you wash your hands between every patient on the floor, that is a good way of getting preventing infection getting transferred to one to another. Create a clean environment in the ward so that dressing changes becomes in a sterile way. Wear sterile gloves and do not reuse soil dressings. In the emergency department, it has always been seen that early administration of antibiotic lowers the infection rate in emergency. In an emergency, if you have a medical officer, resident, whoever is on duty, if he takes a photographs of the wound and keeps the wound covered and prevents not to open up the wound every time a senior surgeon comes in, that exposes the wound less and there is less chance of infection. After the dressing you have been applied in the emergency, it is better to stabilize so that there is no more soft tissue injury by the fracture ends. And if there is plastic surgeon available, consult. So it's a multidisciplinary approach you need to. So in the emergency, it can be planned and decided how we are going to handle a case like this. In the operating room, while after doing the debridement in an open case, you should change your gloves and implant and instruments you have used so far. In the back tray, the implants that are remaining, you should keep them covered till they are used. And please pay attention to accidental contamination of trays, sets, equipment. This is very important. This can decrease the number of infections you are getting. Another important, there is no replacement for meticulous debridement. We have said before is that meticulous, gentle debridement is a key to reduce the number of infection in every cases. Handle the soft tissue with greatest care. Do not use the cautery too much. Do not hold bigger amount of soft tissues with forceps. Do not retract too much. Do not remove the periosteum or muscles. That means you must be as gentle as possible while handling the soft tissues or the bones while doing surgeries. So if you can keep this good practice, you are going to win. The patient is going to suffer less. So you will have less number of infections. So we have come near to the end. The summary is you must have an early diagnosis and adequate debridement is essential. You need to put early administration of antibiotics in emergency department, which can help reduce the infection rate. The good practice, I repeat, the good practice in the emergency department, clinic, ward, and operating room has a huge influence on the reduction of the infection rate. Stability of the fracture is mandatory to control the infection. Loose implants should be removed. Now we'll enter into the live question and answer session. Please submit questions via the chat room. Yes, Dr. Banza, any questions?
Yes, Dr. Kibria. The time you were talking, I was receiving a couple of questions, and I've tried to answer to some of them, and I was keeping some for this live discussion. The first question, there is one of our participants from Malaysia. He would like to know, how do you determine the depth of infection? Because he said, do you use just a clinical examination or imaging? Because sometimes the patient can present early while you don't have, sign of infection on the radiograph, on the X-ray. So how do you know that this infection is deep, this infection is
You know that
superficial?
while we discuss about the superficial infection, to keep in mind that it might get the deeper infection, it has involved the bone or not. So while debriding, you can clinically judge on the table that at the same time there is deep infection or not. So you can see that.
Okay.
Based on that, you can add. Or you think you have?
I was thinking the same. Clinically, when you take the patient to theater and you start debriding, you can see that the deep or the deep soft tissue are not involved, and it can be just like a superficial abscess. Clinically, you can see it, especially during the debridement. So I agree with you.
Thank you.
Yeah, the other questions that one of the participants has asked is this one: is there any relation between HIV infection and bone infection after surgery?
Yeah, the HIV infection patients, they are usually immunocompromised. So there is a chance that they might get infection very early, or they might get the infection after the surgery. And the HIV contamination through penetration of needles, if there is, the surgical teams are all at a risk. What do you think? Because in Asia, we don't have much of these cases. You might have been seeing most of the HIV cases in your place. You can put some light on it?
Um, um, to answer this question, I will refer to one of the study which was done in Malawi by one of the orthopedic surgeons, Jim Harrison. He tried to compare HIV surgery in HIV positive and surgery in open fracture, the same group of patients. And according to Jim Harrison, according to that paper, there is a low risk of infection in HIV positive patient when you are doing your surgery. So there is not much to worry about when you have to operate on a patient, who is HIV and you want to put an implant. So there is not much to worry about this. But there was a high chance, in open wounds, open fractures, when you want to on a patient with HIV positive. So that's what I know so far, according to the paper I published a few years ago. Yeah,
Thank you.
thanks. Yeah, so another questions, it's just like two questions. I'll try to combine them. So one of the participants would like to know a bit in detail the muscular technique. And another participant wanted to find out, when do you use a muscular technique? So it's just like two questions, but I'll just try to combine them.
Done much
together.
of these muscular techniques, but I have gone through books and have followed up some of the cases. From there, I can say the first stage is to debride. Usually, if there is no infection or there is minimum infection is there, to control that, you can put the cemented bone graft with the antibiotics. At the same time, you need to develop a pseudomembrane which prevents absorption of the bone graft. Many of the cases they have grafted at the first and it got absorbed. Usually, if the gap is more than 2 centimeter, there is a chance that the grafted bone might get absorbed. So you need to plan and select your case accordingly. So and the membrane is formed best at 5 weeks after the spacer has been placed. So these are the basic knowledges we have. So what you do is that you debride clearly, then you stabilize the bone and put the spacer, and the spacer put the in a way so the membrane grows involving the both ends. If you fall short of the membrane, so there will be a pseudoarthrosis. So, and incise the membrane longitudinally without disturbing it, take out the spacer and put the mercerized graft. Only then there is a chance that this is going to unite. The 9 cases published in a case, they got all the 9 cases united. So this is the basic steps known to me for the musculite technique.
Okay, thank you so much. The next question is one of the participants, he said, according to the WOC, which is the World Orthopedic Concern, recommend that ORIF should be avoided as much as possible in a lower income country.
In the low income countries, all the patients are not the similar. So if conservative, there is a conservative management is always good, because the bad results of an internal fixation is always worse than the bad result of a conservative management. So if can be avoided, that is good. But if you need to do it, our aim is to teach not to get infected. So our aim is to do that as perfectly as possible without getting infected, following the principles in our low income countries as far as practicable we can do.
Yeah.
You want to add something?
Yeah, I just want to add something. But you remember that we need to treat our patients accordingly, and we need to improve things as well. So we can't just say because we are in lower income countries, we can't treat patient with implant. You know, we need to continue treating patient on, for example, skin traction or skeletal traction, because we are afraid to put intramedullary nail because it's going to get infected. That idea, I don't pound much, you know, with that kind of thought. We have to use what we can, but depending on your setting and your judgment. But we need to use the implant. We need to treat, you know, our patient properly. It's not just like because it's a lower income country, we have to avoid the implant. We have to treat patient conservative. You know, even treating patient conservative, it's a lot of time and energy, because you treat patient conservative, at the end of the day, the patient end up with non-union, and you'll come back again to use the implant, you know. So I think we shouldn't start thinking that implant is bad in a lower income country because of the infection. That is my view.
Thank you.
Yeah. There is a participant from Tanzania. I think I have just to read this question. He said, is there a role of exchanging IM nail coated with cement soaked in antibiotics for tibia femoral fracture? Can it be done on the same setting after debridement?
Yeah, that's a very good question. Many of the people in my area also do that. They remove the nail that got infected, ream it. Reaming means there is a debridement. Then they put the nail impregnated with the bone cement and the antibiotic. That is also a way they can do it.
Thank you so much.
Thank you.
Yeah. I think there is another questions regarding the use of tourniquet. When you have a patient with an infected, let's just say chronic osteomyelitis, and you want to take the patient to theater for debridement, one of the participants is just asking, do you use tourniquet or you just debride without using
I think
tourniquet?
it depends on the scenario or the practice of the surgeon and the theater, because if you are doing a debridement without a tourniquet, you might need a lot of blood. So, and if you do it tourniquet, so you might be able to debride very well. But if you are not very sure about the anatomy or the vessels where it is located, you might get injured at the same time. So I think it best is to judge yourself and decide accordingly depending on your own situation. We are giving a guideline so that you can apply it appropriately or based on your needs in your local scenario.
Yeah. Yeah.
Yep.
I have some point to add. No, the idea is not like to have one answer to this question, because some clinicians, they will say they would like to do the debridement without tourniquet so that they can see which tissue is dead and which tissue is viable. So it's, it's an opinion as well. As you said, you would like to go, for tourniquet, you will use the tourniquet. But other clinicians as well, they will say, I would like to put a tourniquet on just in case if the patient started bleeding profusely, but I would like to put it on and to start by debriding so that I can see which tissue is dead and which tissue is still viable. So it's another view, from some clinicians.
Need-based judgment. Thank you.
The other questions from two participants, I think I've just reading two questions from two participants, is how do you judge the type of implant do you use? Because some people said titanium implant is superior to the stainless steel
You see, the
implant. So
titaniums nowadays, they have got a good adherence capability, which prevents them removal very difficult. So if you need to remove the implant sometimes, the titanium becomes difficult. But nowadays, some stainless steel has come up with very smooth covering. So the smoother the surface is, it might get less amount of biofilm. So titanium itself has got smooth surface, so it can get less amount of biofilms. But the important is that whether you choose titanium or you choose stainless steel, the surface, if it is rough, it is going to get more biofilm and more getting infected. But titanium removal is very difficult.
Okay, no, thank you so much. I do agree with you. There is another question from one of the participants from Nepal. Is just asking what is the role of IV antibiotics in patient with infection before taking this patient to the operating room.
Yeah, thank you. That's a very good question. I was expecting it, because in a low-income country, the scenario is different. The patients might come with the organism known, with taking antibiotic, without taking antibiotics. So in a scenario, if you can go for a culture, that is very good. If you know the organism, say for example, they have come with a cultural report, you know the organism specifically. So you can go for the antibiotic early, but you need to add that 1 to 2 hours before surgery. And if you are not, the organism is not known, you debride, send the tissues for culture, and then you put the antibiotic. If you are using a tourniquet, then before releasing the tourniquet for 10 minutes before, you give the antibiotic. So the scenario in a low-income country is a little bit different. So the guidelines is that you need to identify the organism and add the antibiotic accordingly. So in your scenario, you choose accordingly. Add something?
No, I agree. I agree with you. And the next question, I want to combine the two questions from two participants. Here is the question. You have a patient with an open fracture. You have used an external fixators. When do you decide to convert this treatment into ORIF?
Thank you. That's a very good question. Good question. It can be even once the swelling has subsided and you think there is no infection, even the next day you can change it to the internal fixation if you want to. But it depends on, you look at the wound, how does it look? If it is free of infection,
yeah, so we do still have many questions, but because of time, I would like to ask you the last question from one of our participants. Is the use of the antibiotics. For how long do we use the antibiotics? If you said this patient has got an infected implant, and you want to keep the implant, still, for how long are you going to put this patient on antibiotics? That's one of the questions. Okay. The second question from this participant, when you remove the implant, for how long are you going to keep this patient on antibiotics after you have removed the implant? So this is probably the last question.
Thank you. See, the clinical scenario in low-income countries may be different. So you might have to choose your antibiotic duration depending on the local culture. But the book teaching is, if you are giving an antibiotic with implant, it should be continued for 3 months. 2 weeks, preferably intravenous, followed by oral. If you have removed the implant and you are treating an infection, you can continue it for 6 weeks. That is the basic guide.
Thank
but
you so
this
much,
basic
Dr.
guidance
Kibriya.
you must use along with your experience and local culture
wish we
for the
continue
safety of the
to
patients.
discuss and talk more, because there are plenty of questions, very interesting questions, but because of time, I think we have to stop there. Thank you so much to all our participants from my side. Thank you, and I say goodbye, but we'll continue answering some of these questions offline. Thanks.
Thank you, Dr. So this is a X-ray. You can see this is a lady of 70 years old. We went for a conservative management of 3 years. She declined to undergo surgery. After 3 months time, she came up with non-union. So we had to went for a fixation and a bone grafting. So as somebody has asked, they suggested that low-income countries should not go for internal fixation. I think we have to judge based on our local scenario. So the take-home message is that long bone osteomyelitis is difficult to treat and responsible for significant morbidity and cost. It sometimes needs a multidisciplinary approach. Algorithms exist but not yet perfect. So we need for a clear definition that is finally going to help to establish good algorithms which can be used worldwide. So once you look at these two pictures, so sometimes it's very easy. In this picture, it is very easy to diagnose. Sometimes in this one you are suspicious. There may be, there may not be. So in a scenario, the best thing is the first step is a sound clinical examination. Examine clinically to decide whether there is an infection or not. So I acknowledge my thanks to AO Alliance Curriculum Development Task Force, the AO Foundation, AO Trauma Education Institute, Dr. Stephen Cates, Dr. Olivier Borens. Before I end up, please stay with us for the next 10-15 minutes so that answer to the chat lines. One information is that This webinar has been recorded is recorded, and in few days you will get it in the website. So you can EU Alliance homepage. You can see there. Thank you all, and we're going to end up here. Thanking you. So we'll be answering few of your questions through the chat line. Thank you.